Right. Good afternoon, everyone. Hope you are all well this Tuesday in no late November. Today's speaker is Marta Ribes, who is a PhD student from ICE Global, and I'm really looking forward to hearing about her talk today. So, Marta actually started her PhD on COVID, and then after watching a screening of the documentary Restoring Dignity, which a lot of us have seen, she decided to switch her subject over to Noma and investigate the disease through research and outreach activities focusing on Mozambique. So today she's going to be talking about her research that she's done in Mozambique. Really looking forward to it, Marta. So, floor is yours.
Thank you, Stuart, and the network for giving us the platform to share our project. And I'm super grateful to see all the people connected, and looking forward also to your comments and your feedback on it. So Noma Acres was a project that yes, it was born 2 years ago after we developed some interest in on what's happening in Mozambique. Nobody's speaking about Noma there, and so we developed this project in collaboration with the Departamento Provincial de Saúde, the provincial department of health in Zambezia, Mozambique. So the results of this project are not published yet. The manuscripts are being processed under peer review. So what I will present today is unpublished data so far. So yes, this is the question that I got so many times. Is there Noma in Mozambique? Well, despite not being any scientific evidence so far, yes, there was Noma, and this was no mystery. In the side of scientific reports reporting it, what we knew a year ago was that the review by Anais Gali and colleagues, they had identified 3 scientific articles reporting that Noma was occurring in Mozambique, but they were not reporting any specific patient. And then we came to know as well that the Ministry of Health had conducted a rapid assessment where they were checking the medical records of the main hospitals in the country, and they had identified that yes, there had been patients in all the hospitals that they checked through all the provinces in the country. And then very importantly, we also had informal reports of doctors and epidemiologists who had worked in Mozambique and said, yes, I saw patients during the civil war, for example, or patients that attended Operation Smile surgical campaign. So this NGO that does surgeries on cleft lip and palate. And so Noma survivors were attending these campaigns seeking to receive surgical care. So this was the information that we had so far. And so our main objective was to create scientific evidence to support and to say to the scientific community and academia, hey, yes, Noma is still occurring in Mozambique. And from there, to start building up more research and policy. And then harnessing the fact that we were going to visit many places within the province. We also, and many health facilities specifically, we decided to evaluate as well the knowledge, attitudes, and practices of health practitioners in Zambezia province towards Noma. So these were the 2 main objectives of our study. So our study area, so Mozambique is situated here in Austral Africa. It's a very long country. It has 32 million population for the whole country. And then Zambezia province is here at the center of the country. And it has a population of 5 million, of which over 60% are kids. The surface of Zambezia is actually quite big. It's equivalent to Portugal. And in this area, 60% of children live in poverty. 85% do not have proper sanitation at home, and there's a 45% malnutrition prevalence. The ratio of dentists is 1 per every 70,000 people, and as a comparison here in Spain, it's 1 for every 1,200. So there's a very, very big scarcity of specialists. And another figure that is also interesting for Noma is that there's 3 plastic surgeons for the whole country, and all of them are based in Maputo, which is the capital and is far south. And there's a total of 14 maxillofacial surgeons. In Zambezia, there's 2 maxillofacial surgeons and a visiting one. And they are all based in Quelimane, which is the capital city of the province that is situated here, and which has the reference hospital, which is Hospital Central de Quelimane, the central hospital that is a quaternary level, and that in this case hosts the 2 only maxillofacial surgeons for the 5 million people living in the province. So this was the fieldwork team. We were 2 epidemiologists and 4 dentists, and driver and mechanic, which was very actually indispensable, because we traveled over 7,000 kilometers. So the study procedures were these. We visited different districts within Zambezia. So if you see here, the province is subdivided into 22 districts. And so we tried to visit as many of them, and they were chosen on a convenience sampling basis. Basically, if we knew that a Noma survivor was living there, because we knew them from their surgical campaigns, the Operation Smile surgical campaigns, or because it was on the road to somewhere else. So districts were chosen on a convenience sampling. And then in each district, we replicated this methodology, which basically consisted to visit the health facilities, where we did the CAP questionnaire, the knowledge, attitudes, and practices evaluation among health practitioners, and then where we visited the community for case finding to identify Noma patients. So I will start with the CAP questionnaire, CAP study. So the CAP study consisted on a questionnaire, a paper questionnaire that you see here, that was administered to health practitioners. And health practitioners were chosen on a quota sampling basis, meaning that we would try to get a sample that was representative. So trying to get a nutritionist to participate, dentists, technicians, nurses, maternal health nurses, pediatricians. So it was not random. This was a very small project with very little budget, and as you see, very little human resources as well. So we tried to do as much as possible, but this was the methodology that we could use. And so how we did it was that we introduced ourselves in the health facilities. We chose 1 to 3 people to participate, and then we explained that we were doing a study on neglected tropical diseases. We didn't mention Noma, and if they were willing to participate, which most of them did, just 1 person rejected, then we administered a paper questionnaire. And then this questionnaire, it was one of the researchers that ask the questions, as here my colleague Milagre was asking this doctor, and we would write down the answers, and this was then digitalized by two people and compared by a third person. And so once they had finished the questionnaire, of course, we were in a health facility and we could not leave without sharing and building capacity on Noma management. So we had some posters where we were showing the stages of Noma and the symptoms for each stage and the management, the treatment. So these were the results. We had 41 participants that were balanced in female and male. Over half of them were working at primary health centers that you can see here in the map as blue spots, mark the health centers where at least one participant was working. And we also had participants from the central hospital in the capital of the province and the general hospital, which is a tertiary health facility. And then over 70% were pre-university level professionals, and 30% were university level, 27%. So we had one nutritionist participating, 3 physicians, and 7 dentists, and then the rest were either technicians or nurses, which actually constitute the majority of the workforce in Mozambique, right? As I said before, the ratio of people to dentists is very, very low. The majority of the workforce in Mozambique is constituted by nurses and technicians. And as you see here in the map, most of the participants were working in the capitals of the district, as you can see by a black spot. And this was basically because it was what we could reach with the few days that we had of field work. We had to introduce ourselves to the governments in the districts, and so we would start by working in the usually district hospital, rural hospital that is in the capital of each district, and then if we had time, we would go to some other health facilities inner in the district. And among the participants, very interestingly, 56% said that they had seen a case of Noma before, and this was asked quite broadly to account for patients that they might have encountered in the streets. But when asking them whether they had attended a patient of Noma themselves, 26.8% said yes. And this is actually quite high, and comparing it to other studies, for example, the CAP study done in Zambia found that 11% of their participants had attended a case, and it was 7% in a CAP study in Burkina. So this percentage in Zambezia, in Mozambique, is much higher, but we believe it's because we were also including university level practitioners, which in Zambia and in Burkina were not included. They were mostly including healthcare workers and nurses. But still, it would be a bit bigger. It would be 13% if we only consider pre-university professionals, but similar to what was found in Zambia. And so the first questions that we had were what were the practices of these practitioners? So we were asking them the frequency in which they would do an oral screening to patients being attended for these conditions. So 89% said that they would do an oral screening to HIV patients, 80% to malnutrition patients, and 61% to malaria patients. And these are similar to what was found in Zambia and Burkina, but I suspect there's some response bias here. Yeah, people health practitioners, of course, answering what they would think is the correct answer, rather than them doing this practice, this high percentage of screening. Then on management competence, so until this point, we had not spoken about Noma disease, so they were not aware that we were doing a study on Noma, and we presented the participants with 3 practical cases. And these are the photos, and they were accompanied by some questions, and by some sentences. And so the first one was saying that it was a 2-year-old child that had gum bleeding and bad breath. And only 12% of the health practitioners correctly diagnosed this as an ulcerative gingivitis. Most of them diagnosed simple gingivitis, which would not exactly have the same treatment, right? And then, sorry, I forgot to say here that this was open questions. So the participants did not have a multiple choice where to choose from. The answer had to come from their knowledge directly, right? And so we were asking them as well which treatment they would give and which advice. And then we attributed these answers to some scores. This in the manuscript, it will be detailed, but now I didn't have the time to explain everything. But the scores were this, as you see here. So for case 1, the participants with a pre-university level scored 0.75 out of 3 for the case 1 when integrating the score for diagnosis, treatment, and advice, which was higher at uni level, which was 1 out of 3. Case 2 represented a child with Noma stage 2, and the description that we were giving besides the image was a child that has fever and edema on the cheek, and only 5% correctly diagnosed Noma. This was 9% in university level participants and 3%, so only 1 among pre-university level. It's true that the explanation was not, there was not much information associated with this case, and we know that it's hard to diagnose Noma at this stage, and we were not providing information on like there's also gum bleeding inside the mouth, or there's an ulcer inside. This is true, we didn't provide any information, but the suspicion of Noma was very, very low at this stage. Many people said it would be an abscess, they would diagnose an abscess, and I don't remember exactly the percentage now, but a high percentage would administer amoxicillin at this stage. Very few metronidazole, I think it was 15%. And very few as well would refer. Only 24% would refer at this stage, which is critical, because we know that from this edema to gangrene, it can happen within a night. And it was actually the case of 2 survivors that we met, that they said that it happened through a night, that they woke up with a black spot on the cheek. And so the scoring at stage 2 was very, very low, as you can see here. And then for case 3, their scores were a bit better. 46% could diagnose Noma at this stage, 82% among university level, and 34% among pre-university level. But it's true that still 21% of those who later said they had heard about Noma they could still not diagnose this as Noma. So I'm advancing to the knowledge, specific knowledge of Noma that was very poor. And so this was significantly different. So the university level practitioners, so nutritionists, physicians, and dentists had a significantly better management score than pre-university. And when we categorize these marks in between categories, so very low, under 25% of the score, suboptimal 25 to 50%, and good 50 to 75, you see the percentages here. So it was very low. The majority of pre-university, so technicians and nurses, scored very low, and the majority of university practitioners scored suboptimal. So between 25% and 50% out of 100. And then after these practical cases, we said, okay, do you know what Noma is? And 59% said yes. And actually, this is, for me, it was quite surprising. I didn't know. I didn't expect it would be so high. But then the truth is that the knowledge among them was very poor. So among these 59%, so 24 participants that said, yes, I've heard of Noma before, only 17% knew that the mortality rate was 90%. Only 12% knew that the progression is 2 weeks. And these options were close-ended questions. So they had the answers and they had to pick. And the thing is that many picked that mortality was 10% or they didn't know, and many picked that progression was 3 months or a year. So truly, even if they had heard about Noma, the knowledge that they had was very little. And management practice, as we've seen earlier with case management, was poor as well. And so we asked more questions than the ones presented here. I just did a summary here, and these were the marks. These marks are out of 12.4, so it's better than the management, but this is likely because we were giving them close-ended questions. So the answer was there, they just had to pick the good one, right? And when comparing to the CAP questionnaires in Zambia and in Burkina, we can see that in Zambia, where this specific knowledge was evaluated with open-ended questions, the specific knowledge was also very low, whereas in Burkina, the results are very similar to ours. And so these are the conclusions. 60% of the health workers interviewed in Zambia had heard about Noma. 26% of them had attended a patient themselves. Noma treatment was available. We were asking whether they had the amoxicillin and metronidazole, and they were saying, yes, we have. Sometimes there's shortages, but yes, they do. They had wound debridement and nutritional supplements. But very few know its progression time and its mortality. So it's not a matter, what we conclude is that it's not a matter of lack of access to treatment, it's a matter of lack of access to timely and appropriate care. So I think it's clear that there's an urgent need to train everyone from traditional healers to surgeons, and this is a big limitation of our study, and is that we didn't include traditional killers or healthcare workers, which we will see later are the ones that are probably going to be the first point of care for Noma patients. But certainly the level of knowledge among them will be very low. Right now in Mozambique, Noma is only included in the curriculum of dentists and maxillofacial surgeons. pediatricians do not study Noma, not even during their residency, unless they by chance encounter a patient in their wards. So I think it's clear there's an urgent need to include Noma and to train every level of the health system in Mozambique. Okay, so until now it was the CAP questionnaire, and now I'm going to explain. I think I took a lot of time. Let's see if I have time to explain this, which I think was a bit more interesting. So to provide the evidence that Noma is still occurring in Mozambique, we developed a methodology of a mix of passive and active case finding. So the passive case finding consisted of communicating to the maxillofacial surgeons, stomatologists, and pediatricians in the main hospital in the province, so this quarterly level hospital, telling them we're doing this study. If there's any acute Noma case admitted and in the hospital, please let us know. So we will try to collect information to report an acute case. And then to identify Noma survivors, so people that had Noma some time ago and that survived and are living with the sequelae, we used community-based active case finding. And so this strategy was inspired by the strategy used by the smallpox eradication campaign, which consisted of showing posters of illustrative photos of the disease. So in the case of smallpox, they were also showing the scarring in the skin, right? So we use this because the sequelae of Noma are striking enough for people to remember having encountered someone. And so the strategy was to show this poster to crowds of people and ask to the general population, have you met anyone suffering from this disease? And so at the beginning, we were showing it to health practitioners because we had just conducted with them the CAP study, but we soon realized that they were not very informative, and we turned to the crowds. So we would show the poster to people waiting in waiting areas like here, and then to markets. And so we would say, have you seen anyone with this disease? And if anybody, an informant, came up and said, yes, I think I've seen someone that lives there. And so we would say, was the person born with it? And this was because we needed to rule out a possible confusion with cleft lip. And so if they said, yes, the person was born with it, then we would suspect it was a cleft lip patient. But if they said no, we would say, okay, did the disease occur rapidly? And we would try to visit that person. So we would try to get their address or to get this informant to bring us to the person. And usually people were super nice and they would bring us to that person. We visited them the very same day, because we were just spending a couple of days in each district. So we said, we have a car, we can go with you, or you can tell us who to speak with. And sometimes we had to introduce ourselves to the village chiefs or to elders, but in general, it happened very rarely that people would not help us more. In general, they would come with us to the house of the person, and it also occurred sometimes that we would arrive to the house of the person and the person would not be there. But once we were there with the patient, we ascertained, okay, so this occurred when you were a child, you were not born with it, etc. It occurred very rapidly, and we ascertained that it was very likely a Noma case. And then we explained that we were doing a research study and that we wanted to collect some information. And all of the Noma patients that we identified, Noma survivors, accepted to participate, and they were very grateful that someone was caring for a disease that was affecting them in so many ways, and they had never had a diagnosis. Almost no one had been diagnosed. Some of them had heard about Noma when they went to cleft lip surgical campaigns, and they said, no, we cannot treat you because what you have is not cleft lip, it's Noma. And so we collected the consent, which usually implied having a witness. And then we filled in a questionnaire where we were collecting information on risk factors, disease progression, and social and functional consequences. And as much as possible, we tried to have during the interview some elder person as well, because the patients themselves, the survivors, they could not truly remember because they were very young when they had the disease. So they just knew what they had been told. So, for example, here in the case of Nelita, the lady with the white T-shirt, she could almost not remember anything. So she said, come to my house and there my mom will be able to explain you more. So the woman behind was her mom, and she could explain us more details. So this was usually the case. As much as possible, we tried to get someone that saw the disease occurring, and then we obtained photos. And so these were the results. We identified 23 Noma cases. 2 were acute cases that were admitted at the Quelimane Central Hospital through the 5 weeks that lasted our field work. So through the passive case finding, there were it was a little boy, 3-year-old, and a 4-year-old girl. And through the active case finding, which in which we worked 24 days, we identified 21 survivors. 4 were known already from the cleft lip campaigns, meaning that we already had their contacts and when we arranged a visit with them, and 17 were met through active case finding, so through showing these posters. 14 were informed by informants in markets, 2 by informants at waiting areas in health facilities, and 1 by a health practitioner. And this was very surprising to us, and it was the fact that literally in 10 minutes, by showing the poster 10 minutes in a market, we could get 1 informant. And this was repeated in almost every district. It's true that in Quelimane it was not the case, and we believe it's because it's closer to the capital and then less likely that Noma is occurring. But everywhere else, within 10 minutes, we could get an informant that was telling us, yes, I know someone who has this type of sequelae. And as you see here in the map, in blue are the places where the Noma survivors that we met had the disease, so where they were living when they had the disease, which is almost in every case the same place where they are living now. And as you can see, they are very close to the capitals of the districts, which just means that we met them because we were looking for them around there. And the places where there are no cases is just because we didn't have more time. Because when we found an informant, we left to visit that person. But if instead of 10 minutes we had waited more time in the market, I believe we would have found many more informants, and we would have met many more Noma survivors. And so these were the characteristics of the patients. These are the profile photos of the 21 Noma survivors that we met. And these are the characteristics in the table. And one interesting thing that confronts a bit the literature so far is that 45% told us that they had Noma when they were less than 2 years old. And usually Noma, we say it occurs between 2 to 6 years of age. And it could be that there's a recall bias, of course. However, they were telling us I could still not stand up, or I was still breastfeeding, which are some childhood indicators telling us that that child was less than 2 years old, and this was sometimes reported by the mom as well. So I don't know, of course, we cannot say anything, and not even because of the methodology and because of the low sample size, but I would like to explore this a bit more to see maybe if there's any geographical difference, because we know that a lot of the information that we have so far comes from West Africa, Nigeria, Niger, Burkina. So let's see maybe in the future projects if we can evaluate this. Then more interesting things, 50% said that the first care was sought at a traditional healer. And I would say that they were just going to what was closer to them. So it also happened that the first care was sought at a provincial hospital because she was living close to that hospital. It was the closest that she had. It was Rosa. She went there because she was living in Quelimane, so it was the closest that she had to her house. And then interesting as well to see that some looked for care before the gangrenous stage, meaning that if the health workers at that place where they sought care had known about Noma, had known about its aggressiveness, and had been able to administer the antibiotics, which we know at present it's possible. Maybe it was not possible when these people had Noma, if it was during the civil war in Mozambique, who knows? But it would have been on time to revert and to not arrive to the gangrenous stage where the tissue is lost and then you live with the sequelae. And then very interesting as well, 57% of them had sought care at surgical campaigns of cleft lip. And 43% of them had met another person with Noma in their lives, half of them during these surgical campaigns, but also 23% of them had met another Noma survivor just in the streets close to where they live, or had encountered someone who had suffered Noma as well. So these were some of the risk factors that we evaluated. Of course, this is as well subject to recall bias. 68% said they had received some vaccination. Breastfeeding mean duration was 13 months. 44% said they were living in a situation of food scarcity when they suffered acute Noma. Of course, this was all asking them, okay, just before you had the acute phase, what was the situation at your house? Then 70% had a disease prior to Noma. Many could not remember. That is true as well. And the most reported diseases were measles, malaria, fevers. And then regarding oral healthcare, 23% said they did not use any cleaning measure when they had Noma. 29 used mulala, which is a root, like a stick that is quite common in Mozambique, and it has antibacterial properties, and it helps to clean the teeth. So there was a variety, so to say. And then we were asking as well about symptoms at the acute phase. And of course, a lot of time had passed. And as you can see here, over half could not remember most of the symptoms. But there's some interesting things as well here, and is that, for example, not all of them remembered about necrosis, and some said they did not have necrosis, which is not possible for Noma, right? So I think what this tells us is that probably usually necrosis, we were describing it in Portuguese and translated to the local language as blackened skin. So maybe there has to be some research done to adapt this to the context to see how we can explain better the symptoms. And then very interesting as well was that without asking, because the first thing that we did when we encountered a Noma patient was to say, okay, tell us everything that we need, everything that you remember. And so we would write everything down as a story, and then we would ask specific questions, right? But it was very interesting to listen to their stories, and 56% mentioned that the disease started with a blister. For those speaking Portuguese, they said borbulha. So yeah, for me this was interesting to realize that that many of them said their start was a blister to their perception. And then we evaluated the social and functional consequences, and this very much varied between every survivor, and at the end the sequelae were different, and then the social situation of everyone was different, and it was very moving to listen to their stories. In this case, Antonio, who is a market vendor and a pastor in Morumbala, he said it was Portuguese time. There was no hospital. It started with some eruptions covering the whole body. It was measles disease. And then he went on, my father rejected me, so I stayed with my mother and grandfather. My father took the rest of the kids with him. Now they are all dead but me. So this was in the context of the colonization by the Portuguese, and then Mozambique suffered the independence war and then the civil war until year 1992. So it was a hard time. And for example, in the case of Antonio, he was rejected by the family, but then the fate brought him to now living a very nice life, and we met him with his cousin and a friend, and they were just super happy, and he has a church. So it also depends a lot on the survivors now. But then we've also met another boy much younger. He's 20, and he also works at a market, and he has complete trismus, and he told us that he chews the food. He cannot chew the food, so he presses it with his thumb against the teeth, and then sucks it to eat it. And so he has had this complete trismus since he was 2 years old. And actually, it was very hard to understand him. It was a friend of him who was doing the translation to us to be able to understand him and to listen to his story and fill in the questionnaire. So 62% said they had stigma, and this. Now I wonder how we explained what stigma was, and maybe we should have taken more time to explain what stigma actually is, and of course this is hard, and they just had met us for a short time, so maybe they were not feeling very comfortable with telling us what the issues were, but the result that we have is that 62 said they face stigma, most of them in education, at school, but 71% went to school after having Noma. Only 15 had issues finding a job, very much because almost all of them were working in the informal sector. And 39% said they had issues with their aesthetics. And regarding this, two of them, which is quite remarkable, the two people said the exact same sentence. We were asking them, what is the biggest issue that this disease causes you? And they were saying, no, I don't have any issue. If anything, people have issues with me. So I think this is very, very telling from the stigma that they face. And then regarding functional consequences, you see here that 37% had trismus. And so when putting the years where these people had Noma, we see that the one who had Noma the longest time ago, she had it in 1971. She's now 60 years old. And the survivor who had it the most recent, who is a 13-year-old now, he had it in 2015. And then this in 2024, these are the two acute cases that were identified by the passive case finding. So in this plot, what you see are the years of onset of the disease of the 23 participants. And what we tried to plot here was some indicators that we could try to link with the incidence of Noma, with the risk of developing Noma. So we plot here the protein consumption, you see in the colors, right? So protein consumption is in pink. In yellow, we have the HIV deaths that peaked in Mozambique around 2005. And in green, we have the malaria cases. And so as you see here, and then you have the bars of the Independence War, which finished in year 74, and the Civil War, which went from year 77 to 92. And you see here a drop in measles vaccination coverage, which we know that measles is one of the diseases that usually occur prior to Noma. And it's very few cases, but we could see here that there's a cluster of cases occurring by the late years of the 80s decade, just after this drop in measles coverage. And actually, Rosa, this lady from Quelimane, she mentioned that she explained to us the disease, saying, well, the disease reached everyone in my village, but only I stayed like this. Only I got this loss of tissue. And maybe what this represents was a measles outbreak, where she was the one unlucky to develop Noma afterwards. Another interesting risk factor that I think should be further evaluated is HIV, which has a higher prevalence in Mozambique than in West Africa. So I think in the future we should explore that more. And so we tried to estimate the incidence with the data that we have. Of course, is not perfect or anything close to, but we use the WHO formula, adapting it with the attendance rate reported by our participants. So WHO formula uses a 5% attendance, but we used an 18.75 because it's the attendance rate of participants that went to the highest level of care. So assuming that 4 cases are attended per year at Quelimane Central Hospital, which is what maxillofacials say that they receive per year, and assuming an 18.75% attendance rate, which comes from the survivors cohort, and a 10% survival rate, then we get 13.7 cases for every 100,000 children 0 to 9 years old per year. So this is similar to the incidence calculated in Ethiopia and in Nigeria in a retrospective study published in 2019. And if instead of having an attendance rate of almost 19%, we had calculated it for 5%, as WHO recommends, then it would be 50 cases for every 100K children. So coming to the conclusions, this study allowed us to conclude that Noma is still ravaging lives in Mozambique and has been doing so through the decades, despite the outrageous lack of reporting. And this leads us to think that wherever poverty persists, Noma might occur. It's not that we are not seeing the cases being reported. It's not that health professionals are telling us, no, I never saw a case. It's not that. Patients are there. They are far from the health facilities sometimes. Sometimes they are very close, but sometimes they are just not visible to the statistics, right? What we have heard many times. And I would say that this study was relatively easy to implement. We needed few resources and few so actually I can say the cost was 10,000 euros. So I hope it can be replicated in many places, considering that this for some research is not so much. And few human resources as well, and it can help to provide the first evidence that is needed for funders to give more money to then do more research and more policy. And then future plans from ICE Global. So we are working on a systematic review and meta-analysis of the clinical features of Noma. So for this, we are we are reviewing every case that was reported on Noma in many languages and since ever. So reviewing the papers of the 19th century as well. And there's a battalion of volunteers extracting these cases. So if some of you are connecting, thank you so much. And this is led by Patricia Siebels. So we are working on it. We are still extracting, but it will be very big. It's around 900 cases that have been reported. Most of them have very little information, but what we're doing is extracting the symptoms that were reported, the temporality. So when does this symptom usually happen? Does it happen before or after the other one? How long does this symptom last? The frequency of prior disease, the frequency of other risk factors. And the idea is to put numbers to the clinical description that we have so far by the meta-analysis of all this data that is available in the case report. Then with Romina, who is a master's student now of global health, we are planning to do an assessment of cases identified or treated by health workers in Latin America, and a CAP questionnaire. So basically to ask in some countries, not in the whole continent, but in some countries, to ask key people, have you ever treated a patient, to update a bit the information that we have from case reports that in Latin America, mostly they date from early 2000s or earlier on, to see if there's still Noma occurring. And then we have also integrated some questions on Noma into a larger clinical trial that is going to happen in Zambezia, the same province where we were in Mozambique, where we will be able to see the proportion of children with each of the Noma stages at admission in a health center. So very similar to the ANCA study that was done in Nigeria. And then more on the, so to say, I don't know if to say humanitarian side, but less academic, is the collaboration that we're doing with Elysium. So I got the chance to be helped by them with the questionnaire on Noma, the questionnaire that we used with the study, where they reviewed it, and then they are also linking to the survivors in the capacity that is possible to the survivors that I met in Mozambique. So in the case of Baba, for example, he is now linked with the Noma Survivors Association. And then we are also planning a surgical campaign to happen in Quelimane in next year, where we will try to offer in as much as possible surgical care for the survivors that we met during our study. So that's it. I thank so much everybody that participated in the study, and for you for attending. Thank you.
Thank you very much, Marta. That was absolutely fascinating. Lots and lots of information, huge amounts of information.
Yeah.
It's really, really exciting to see. Have we got any specific questions for Marta? I think I'll just start with one. So you mentioned that some of the survivors had met another Noma survivor during their lifetime. Did any of the survivors suggest that the people that they'd met were living close by to where they were living? Because obviously, if that person has had Noma, they are living in the environmental conditions where Noma is possible, it's potential. So I was just wondering if they were, what was the relationship with the other people they'd known? Is it just simply chance acquaintance in a market, like you said?
Yeah. To my perception, it was relatively random. Like nobody told me, yes, my friend or my neighbor. Like some were living relatively close by, but nobody mentioned that they were living in the same I don't know, compound, village. Like, yeah, two of them were living in the same city right now, but I think during the acute phase, I don't think, no, they were not living in the same city. And two others, yeah, they were living relatively close, like by car it was 5 minutes, but not next to each other.
That's interesting. Laura, you have a question.
Hello all. I'm Laura from Italy, and I'm studying in Ca' Foscari University. I'm preparing my thesis on Noma for my magister degree in medical anthropology. So thanks a lot, indeed. I would like to do the same job in other parts, maybe in,
please do it
in South America. But in this moment, I want to start from Ethiopia. I will go in January in Ethiopia in order to do the first. But thanks a lot. It's incredible, your presentation. And I have two small questions. The first one is about the word burbuja, no?
Yeah.
What do you think about that? What do you, just a suggestion, because for me, from my side, it's very important the existential feelings of patients, no? And so I want to try to catch, to understand what they feel, what they say when they say no, when they say burbuja. Is burbuja in Portuguese?
Yeah. It's a word that
Like
they
in
were
Spanish.
using.
Like in burbuja?
Yeah, in Spanish it's not exactly the same.
Oh, it's burbuja.
Yeah, but you wouldn't
No.
say burbuja for a medical term. I mean, now I regret a lot that I was not asking them if that burbuja was inside the mouth or outside, because sometimes I felt, and sometimes they said it in plural, and which could be measles. So yeah, with the information that we collected in the questionnaires, I cannot distinguish very much if they were referring already to the wound, if they were referring to like blisters inside the mouth, so still in stage 1.
And there is something of symbolic that you can link with this word.
No,
Or
but
just
maybe
organic.
what's interesting for you is that I didn't share it here, but we were also asking if there's a word in the local language for Noma, and 60% said yes. But it differed from one person to the other. But it's true that their languages also differed. In Zambezia, there's, I think, over 7 different local languages. And some of them were referring to animals. Like I remember one was referring to a disease that pigs usually get, and it's like similar. Some others were referring like a bite of a dog.
Yes. Thanks, and thanks a lot.
I can share it with you if you need.
Thanks. I will send to everyone my email on the chat, and if someone wants to contact me, I'm happy. And other stuff is about the research in South America. I have been in Chile for studying, and in my opinion, because I was looking for Noma a bit, no, Argentina is a good place to research. North of Argentina, for example, is just a suggestion, and I would like to do a study there after my magister, maybe, so we can stay in contact.
Yeah, of course.
Thanks a lot. I will type my. Okay, thanks,
Laura. Marta, we have, I know we're running a little bit over time, so Stu had to leave, so I'm just going to take over chairing, but we have a few questions in the chat, so I hope you don't mind staying a little longer. One from Matisse. Thank you. And he's asking, who are you partnering with in the planned surgical campaign?
With Elysium, we are organizing it with Elysium, and of course with the colleagues from the Department of Health in Zambezia.
Perfect. Matisse, if you have any follow-up questions, just pop them in the chat. And then we have another one in the chat from Dr. Sarao, the Noma expert from Lao. Would you like to ask your question?
Oh, yes. Thank you very much for your excellent presentation and your research and the unique methodology, which I think will be very valuable to find the cases. I think you've clearly seen how common this so-called rare disease actually is, and very important results that you reported, including saving the lives of 2 children with acute Noma. So that's very important. Do you have a plan to offer education to these healthcare workers who so badly need education about NOMA? That's my question.
Yeah, there's thank you for your question, and yeah, there's the plan to work on that from the Ministry of Health in Mozambique. Yeah.
Great, that's excellent. And thank you for also telling us about the plan to offer rehabilitation to the survivors of NOMA. I don't know how much experience these doctors in Mozambique have in NOMA surgery. So hopefully other teams with international experience will be interested in joining them when your research is published. We look forward to that. Thank you very much.
Thanks to you.
Thanks. And then there's one more question from Dr. Ade in Nigeria, and he's asking if you found any acute NOMA cases in under 5-year-olds during the research.
Yes, 2 of them. Yeah, they were attended at the Kelimane Central Hospital. They had been treated before at the district hospitals, and they were transferred with the ambulance to the central hospital. Yeah, 2 of them. One was a 3-year-old boy, and the other a 4-year-old girl. Both of them had type 1, so on the cheek. And both of them were born to mothers with HIV. The boy was not HIV positive, and the girl, she was.
That's really interesting, and sort of leads me on to a question that I had of my own. And you mentioned that 70% of the patients that you found had reported having some sort of comorbidity in the 3 months prior, and I was wondering what those were. Or I understand the recall bias issue, but I was just out of interest. You mentioned measles.
Yeah. I don't have the numbers exactly, but it was mainly measles, malaria, some saying fever in general. And I regret it a lot, but we did not collect HIV. So I don't have the information for all of them, just for the ones who were mentioning it.
No, that's super helpful. And some really good news from Petra just about their Health Section NOMA is establishing a bilateral cooperation with the Ministry of Health in Mozambique that will offer training program on NOMA to formal healthcare workers and non-formal community healthcare workers. So it's really fantastic because, what really struck me also from your presentation was how many healthcare workers it was easy to identify NOMA in those late stages, but it's those early stages when we can actually do something, which so few of them, it is so hard, right? It's a very difficult thing. So that's fantastic news. I wanted to open the floor if there was just one last question from anyone, because I know we're over time.
And I will write my email in the chat as well in case people have more questions.
Well, good afternoon once again, everyone. Marta Ribes, that's a wonderful presentation. I really love the research. I was just to ask the sample size you use. Was there a limitation to the number of healthcare you can in the first part of the presentation? Because actually 41 is a small number, but the information gotten was huge. But was there a limitation to the sample size? Was it what you calculated?
So we didn't have a sample size calculation because it was the first time that such a evaluation, such a study was done, and also because the evaluation for health practitioners was a secondary objective. Our primary objective was to identify Noma survivors, which we thought at the beginning would be harder. And in the end, it turned out that it was much more common than we thought. So it has the limitation that it's a small sample size indeed. It was not randomly selected, and then we don't have traditional healers or community health workers. So yeah, it has these limitations. I mean, I don't know, I think it's very useful already what we found, acknowledging these limitations, but I think it is extendable to if we had a higher sample size. I think we can generalize that indeed Noma is not part of the curriculum of any of these professions except for maxillofacials and dentists. So it's normal that the level of knowledge is too low.
Yeah. Okay, that's good. Thank you.
No, it's really interesting, and it would be wonderful if we could take this and sort of, do it all over the world, really. Yeah, you did a lot with a small budget, and it just shows what's possible. So well done, and we're really looking forward to your work being published. And once it is published, Marta, well, we'll share the publications with the network. So we'll be sending that over. And before you all go, one of our committee members, John, would like to tell you a little bit about the work that he's doing on Noma. So, John, are you there?
Yes, thank you very much, Elise. Marta, what a terrific presentation. I would love to keep in touch with you. That was absolutely amazing. Good afternoon, everyone, or good morning if you're in the United States like I am. I am currently a dental student and also a Master of Science in Oral and Population Health candidate at the University of Pennsylvania School of Dental Medicine. And as part of my thesis project, I am going to be running an individualized patient data meta-analysis. So if you or anyone that you work with has published an article on an analytical study on Noma, I would love to get in touch with you that we could work together on this project. I will put my email into the chat, but this is something that we're currently running here at the dental school to look at the pooled risk factors across at different analytical studies on Noma so that we have a higher certainty in the confidence of the evidence related to the risk factors on Noma. So I'll put that into the chat now, and I would love to speak with anyone if they have any questions about this project or in general. I'm so happy to work with anyone related to Noma, and thank you, Elise, for the moment to speak. And Marta, again, what a terrific presentation. Thank you.
Thanks so much, John. And yeah, and I just wanted to say thank you so much to you all. This is our last webinar of the year, and things have grown from strength to strength. We only started in January this year, and we now have 300 people signed up to the network, which is about 10 times bigger than I had ever imagined. So we are thrilled with how things have grown, and we can't wait until next year. And if any of you would like to present on your work on Noma, it doesn't have to be research, but it can be anything you have planned or that you have finished, or that your hopes and dreams for Noma research that you are looking for our network to get involved. Really, it can be a broad spectrum. We really want our network to be a network and to bring people together. So please do reach out if you would like to do a short presentation, a long presentation. We welcome your participation. So thank you so much to you all, and we look forward to seeing you in the new year. So we'll send the invite out. It'll be in January, the first webinar, because it'll be, I think, Christmas Day in December. So I think you will all be busy. Yeah, but thank you so much, and we will see you in January. Bye.